Hello everyone, I'm Jinjing and the topic I'm going to talk about today is clinical interviewing skills for clinical psychologists. This is the list of contents that I'm going through today. First, I'm going to talk about the definition of clinical interview, then followed by the overview of the interview process, types of clinical interview, basic interview skills, and tips for successful clinical interview with older adults. There are videos throughout the presentation, so please follow the link provided and watch the video accordingly. And for the additional readings, I will provide a list of additional reading list at the end of the presentation, and it will be uploaded in iFolio as well. First of all, what is clinical interview? There are three definitions here. Which one do you think is the right definition of clinical interview? A. An interview is a controlled situation in which one person, the interviewer, asks a series of questions of another person, the respondent. B. An interview is an interaction between at least two persons. Each participant contributes to the process and each influences the responses of the other. However, this characterization falls short of defining the process. Ordinary conversation is interactional, but surely interviewing goes beyond that. C. A conversation characterized by respect and mutuality, by immediacy and warm presence, and by emphasis on strength and potential. Because clinical interviewing is essential relational, it requires ongoing attention to how things are said and done, as well as to what is said and done. The emphasis on the relationship is at the heart of the different kind of talking that is clinical interview. So let's take 10 seconds to guess the answer. So no matter which one you choose, you are right. All these three answers are definition of clinical interview by different authors. As you can see from the references I've quoted, some define it in a straightforward way, some define it in a more ambiguous way. From another perspective, a good clinical interview includes the following factors. A positive and respectful professional relationship between interviewer and client is established. Second, the interviewer and client work collaboratively to establish and achieve mutually agreeable client goals. Third, the interviewer applies active listening skills and psychological techniques to evaluate, understand, and help the client achieve goals. The quality and quantity of interactions between interviewer and client are influenced by many factors, including interviewer and client culture, personality style, attitudes, and goals. After defining the definition of the clinical interview, now I'm going to talk about the overview of the interview process. In the very beginning of clinical interview, it's extremely important to establish rapport with clients. Without a good rapport, clients will not be willing to disclose to the clinicians. So clinician can always begin with a warm greeting and clear introduction about him or herself. Then, initial informal chatting or conversation can help to put clients at ease. Ask client how does she or he like to be addressed? Then engage in small talk with empathic concern. For example, asking clients, how was the traffic on the way here? Were you able to find the parking easily? Have you had your meal? After a brief chat, clinicians can educate clients about therapist roles, purpose, and length of this session, as well as confidentiality issue. Also, it's very useful to know clients' expectation about the session. For example, if the client expects to recover from depression in just one session, then clinician may need to educate clients, or if the client would like to get medicine prescription, then clinicians need to explain and make it clear that a psychologist cannot prescribe medicine. The opening statement signals to the client that small talk, introductions, and explanations of confidentiality are over and it's time for the interview to begin. Opening statement is either open question or gentle prompt. Its purpose is to help the clients begin talking freely about personal concerns that have caused them to seek professional assistance. Here are some of the examples of popular opening statements. For example, what brings you here? What can I be of help? Maybe you could begin by telling me things about yourself or your situation that you believe are important. Or you can say, so how's it been going? Or clinician can ask, what are some of the stresses you have been coping with recently? Client's opening response is crucial in understanding the client's personality dynamics. Some clients may have good insight, can tell straightforward why they seek professional assistance. In contrast, some clients may struggle to express themselves by saying, I don't know what you want me to say. What am I supposed to talk about? Interviewers should let clients struggle with an unstructured opening for a few moments because it provides an opportunity to assess client's general expressive abilities and how much help the client needs to express himself or herself. If a client responds to your opening by asking, what should I talk about? Respond warmly with whatever you are like. If the client falters a second time or seems to really need your help to get started, go ahead and offer support and more structured. For example, the client in the second time, the client may say, I really don't know where to start. Then the interviewer can answer like, sometimes it's difficult to know what to say first. How about if you start by talking a bit about how things have been going at home or work or school? As clients proceed during the opening phase of the interview, you should evaluate their approach and begin modifying your responses accordingly. For instance, with clients who are very verbal and tend to ramble, you might need to consider using more close-ended questions. Besides, there are two types of clients, internalizer and externalizer. Internalizers tend to describe their problems as having an internal cause. On the other hand, externalizers tend to believe their troubles stem from other people. So we can look at the examples I provided here. An internalizer may say, I feel so depressed. Nothing I do turns out quite right. I'm underemployed. I can't seem to get involved in a good relationship. I picked the wrong type of woman, and I can't figure out why anyone who has anything going for them would want to go out with me anyway. However, an externalizer may say something like, my problem is that I have a ridiculous boss. He's rude, stupid, and arrogant. In fact, men in general are insensitive, and my life would be fine if I never had to deal with another man again. So we can see the difference here. The body of an initial or assessment interview primarily involves information gathering. Depending on the interview's purpose, the inferences will relate to some of the following: the client's personality, style, acculturation or stress level, recommendations on whether therapy is needed, recommendations regarding the most appropriate therapy approach, the client's mental status and or psychiatric diagnosis, estimates of client's intellectual or cognitive functioning, parenting ability, attitudes and adequacy, suicide or violence potential, addictions, past criminal behavior, past employment and relationship and educational experiences. However, it is not recommended to make statements about the clients based on one single clinical interview. Then the interviewer needs to distinguish between normal and abnormal functioning of clients based on DSM-5. Clinical diagnosis and treatment plan may be made. Tay and Akif have already covered that about these two topics in previous flip teaching, so I'm not going to talk about it again today. Most interventions will be applied after a suitable assessment has been completed. However, in many cases, assessment and interventions are happening simultaneously. Throughout the intervention process, interviewers are still gathering information. When new information comes in, treatment plans need to be revised and make adjustments accordingly. It's not easy to have a smooth closing, especially when clients have so much to talk. One key to a smooth closing is to consciously and skillfully stop gathering new information somewhere between 5 to 10 minutes before your interview time is over. Because clients often feel worried or stressed toward the interview's end, interviewers should leave ample time for closure. It is also important to reassure and support your client. Clients need to have their expressive capabilities noticed and supported. For example, we can say something like, thanks for being so open and sharing so much about yourself with me. Also, the interviewer should support the client's decision to seek professional services. We can say, I want to congratulate you for coming here today. Coming to someone for help can be hard. I know some people think otherwise, but I believe that getting help for yourself is a sign of strength. Then the interviewer should summarize crucial themes and issues discussed in the session. One of the best methods for enhancing a client's likelihood of returning for therapy is to clearly identify during the closing phase precisely why the client has come for professional assistance. Also, instill hope for positive change. Make sure you include a positive statement before closing. Interviewers should make a statement about how counseling or psychotherapy may help address the client's personal issues and concerns. Lastly, it's often useful to ask clients if they have questions or feedback for the interviewer. Explicitly give your client a bit more power and control as the interview closes. For example, we can say, I've done all the questioning here. I wonder if you have any questions for me? Termination. Termination occurs when two parties acknowledge the meeting is over. Interviewer needs control over termination. Interviewer can use a standardized ending, make a warm and comfortable termination statement, discuss termination and time boundaries with your client. If client tries to push the time boundaries, you must stand firm and must end. Clients may express anger, disappointment, relief, or a number of strong emotions at the end of the interview. These emotions may reflect unresolved feelings that the client has concerning previous separations from important people in his or her life. However, it always remembers to stay within time boundaries. I think that's for part 1 today. So let's take a break. Welcome back, everyone. After talking about the definition of clinical interview and the overview of the interview process, now I will briefly talk about different types of clinical interview. So there are 4 types of clinical interview: the intake, admission or assessment interview, mental status examination, diagnostic interview, and suicide assessment. First, the intake interview. It is an interview done before counseling, psychotherapy, or psychiatric treatment. There are 3 objectives of intake interview. First, identifying, evaluating, and exploring the client's chief complaint and associated therapy goals, obtaining data related to the client's interpersonal style, interpersonal skills, and personal history, and evaluating the client's current life situation and functioning. For the first objective, we need to prioritize and select client problems and goals. And also to analyze the symptoms, we can use problem conceptualization system, the basic ID. B, for the behavior, concrete behaviors and the client might like to increase or decrease. So we can ask clients something like, are there some things you would like to stop doing? A is the effect. We can ask something like, what emotions are most troubling to you? S stands for sensation. What happens to cause you those unpleasant sensations? I, imagery. When you are feeling anxious, what images or pictures pop into your mind? C, cognition. When you meet someone new, what thoughts go through your mind? I, interpersonal relationships. What words would you use to describe the positive or healthy relationship that you have? D, drugs. Do you take any prescription drugs? So these are the examples of the questions that we can ask clients during the interview. Interviewers have to obtain 3 general information to assess the client's personality and mental conditions: the client's personal history, client's manner of interacting with others, and formal evaluation of client's mental status. Here are the personal history interview sample questions. This table is extracted from the clinical interviewing book from our therapeutic class. If you can't see it clearly in this video, you can refer to page 187 to page 189 of that textbook. Here are some of the examples of a question interviewers can ask to assess the client's life functioning and their life situation. Okay, so we have learned about the intake interview. Now I'm going to talk about the mental status examination. Dr. Mahadi has already covered quite comprehensively in his class, so I will just briefly talk about it today. The mental status examination (MSE) is the structured assessment of the client's behavioral and cognitive functioning. These are the 9 areas that we examine: appearance, behavior or psychomotor activity, attitude toward examiner or interviewer, affect and mood, speech and thought, perceptual disturbances, orientation and consciousness, memory and intelligence, reliability, judgment and insight. Appearance. Physical characteristics: apparent age, grooming, dress, cleanliness, pupil dilation or contraction, facial expression, perspiration, makeup, and etc. These are the things that we can observe through the client's appearance when they come to the session. Second, the behavioral psychomotor activity. This category focuses on physical movement. Client activity throughout the evaluation should be noted and recorded. Do they have limited or excessively body movement? Absence or presence of eye contact? Repeated motor movements may signal the presence of disorder. For example, dusting off shoes may signify the presence of obsessive compulsive disorder. It's just an example. The third, attitude toward the interviewer, refers to how clients behave in relation to the interviewer. That is, attitude is defined as the behavior that occurs in an interpersonal context. Is the client cooperative, aggressive, impatient, manipulative, open, passive, indifferent, and etc. So these are the attitudes that we can examine. Fourth, is the affect and mood. It may be most difficult to evaluate a patient's emotional state. It is necessary to obtain both the patient's subjective experiences, which is known as the mood, as well as the objective expression of his or her affective reaction that observed by interviewer. Affect. Although people use a wide range of feelings words in conversation, affect content usually can be accurately described using one of the following: angry, guilt, anxious, happy, and etc. For the mood, sometimes the clients may say, "I'm unhappy." Most of the times, we can directly quote from what the clients have said. The fifth domain is the speech and thought. It is primarily through speech that interviewer observe and evaluate the thought process and content of the clients. We can examine the speed of the speech. Is it fast? Is it normal? Is it slow? We can examine the volume, loud, normal, or soft. Thought processes refers to how the clients express themselves. Did they express themselves in a way that show incoherent thoughts, delusions, obsessions? Perceptual disturbances. There are 2 major types of perceptual disturbances: hallucinations and illusions. Hallucinations are defined as false sensory impressions or experiences. Illusions are defined as perceptual distortions, causing existing stimuli to appear quite different from what they are in reality. When clients report such experiences or you observe clients as they experience such perceptual disturbances, the disorder is usually of a very serious nature. Immediate medical evaluation intervention is needed. The 7th domain is the orientation and consciousness. Interviewers routinely evaluate whether the clients are oriented to the immediate situation and clearness of conscious processes. We can ask clients about the day, week, time, date, place, person, self, or in what city they are in now. It's then followed by the memory and intelligence. In MSE, interviewers do a quick memory screening by examining the remote, recent, and immediate memory. Intelligence, we can measure the general information, calculation, reasoning, and judgment. For the insight, Examine whether the client understands and realizes the significance of his or her symptoms and of the situation in which he or she finds himself or herself. Ask the client a possible explanation of the symptoms, of their own symptoms. In summary, formal mental status examinations are not appropriate for all clients. MSE become more necessary as suspected level of client psychopathology increases. The examiner should summarize the important positive psychopathological facts and contributory negative findings as elicited in the MSE. The third type of clinical interview is diagnostic interview. Terry had done a very good job in explaining how to use DSM-5 and how to diagnose a client. So I'm going to talk about the process of diagnostic interview. In an interview, it's important to start with a warm greeting, as mentioned before, followed by explaining about the therapist and client's roles in the session, the confidentiality issue, and so on. It's same as the introduction I've mentioned before. Then reviewing the client's problems, question about the symptoms based on the DSM criteria, associated goals, and a detailed analysis of the client's primary problem and goal. During this process, it is important to keep the diagnostic checklist available. Then we need to gather the information about the personal history, and we do the mental status examination as mentioned before. And lastly, interviewers should evaluate the client's current situation, including usual or typical day, their social network, their coping skills, the physical examination, like questions about their most recent physical examination results. Physical and mental states have reciprocal influences. And lastly, we can ask about their client's strengths or their positive qualities. Establish a diagnosis based on single clinical interview is inappropriate and unprofessional. This is something that we need to keep it in mind. Here are the example of diagnostic interview questions to assess major depression. I get it from an article, so you may need to pause for a while to read through the slides, read through the criteria. Here are the additional readings about the structured diagnostic interview in children and adolescents. I will summarize all the additional readings for today's presentation at the very end of the video. The last type of clinical interview is the suicide assessment. There is possibility that we may interview suicidal clients. It's important for us as the interviewer to equip ourselves with knowledge and skills when we are in that situation. There are many suicide risk factors but this is a general suicide assessment checklist that we can use. In a suicide assessment, it's important to assess the client's depression. We assess 4 major depressive symptoms. First is the mood-related symptoms. Interviewer can ask clients how they have been feeling using the scaling question. I'll talk about the scaling question in the following videos. Also, it's very important to find out whether clients have loss of interest or pleasure in usually enjoyable activities. Second, we also assess the physical symptoms as part of their depression. Third, the cognitive area, we examine the negative beliefs about self, others, and futures. We can ask questions like, how are you feeling about yourself? Tell me about the time when you were feeling particularly good about yourself, and so on. Future-oriented questions and questions that elicit past success can stimulate hopefulness. And also we can examine whether the clients withdraw from friends, family, and usual social activities. It will tell us the social interpersonal symptoms of the suicidal possibility. Then the interviewer tests the personal and family history information, which includes any history of suicide attempts in their family. I've mentioned about the history taking before. It's followed by the exploring the suicidal ideation. we need to examine whether there is a presence or absence of the suicidal thoughts. We can ask questions like, sometimes when people are down or depressed or feeling miserable, they think about suicide and reject the idea, or they think about suicide as a solution. Have you had either of these thoughts about suicide? Then we need to assess the suicidal plan. To evaluate the client's suicide plan, we can use SLAP to examine. S. How specific or detailed is his plan? L. How quickly the plan could result in death? A. How readily is the client? How are things required to commit suicide ready? P. The proximity or closeness of the social support. Then we can assess the client's self-control and past or familiar attempts by asking them, do you ever feel worried that you might lose control and try to kill yourself, even though you might not want to do it right now? Client who has high suicidal intention may not admit it, so self-report suicidal intention is not reliable. Intent is generally assessed indirectly or inferred based on the client's plan, past suicide attempts, and overall demeanor. As an interviewer, it's your responsibility to make the clinical judgment and inform the authority when necessary. Here are two videos and an additional reading. The first video, I've chosen the video that used similar steps I mentioned just now to conduct the suicide assessment. It was the first time the interviewer and the client met. The second video is a suicide assessment that shows subtle warning signs of suicide. The client is a bit reluctant to share about the suicidal thoughts. For the additional reading is the case approach, an approach to conduct suicide assessment. So I will include all of these videos and readings in the end of the slides, and you can follow the link to watch the video, first and second video. After you watch the video, then you can continue with this presentation. There are different kinds of clinical interviews: structured, unstructured, semi-structured. Here are the examples of the structured clinical interviews. So the structured assessment of DSM SS1, SS2, of course for DSM-5, the SS1, SS2 has been combined, and also the focus structured interviews. Structured clinical interview was developed to reduce the problem associated with open-ended interviews. It can reduce the role of clinical judgment and enable comparison between one case or population with another. Structured clinical interview for DSM SCID is the most frequently used structured interview. It is a comprehensive, broad-spectrum instrument that has to be administered by trained clinicians. The latest version of SCID is SCID 5, based on DSM-5. SCID is suitable for different populations and contexts. For the schedule of affective disorders and schizophrenia is a widely used semi-structured interview for clinical research purposes. It was originally developed for different diagnoses between affective disorder and schizophrenia. However, currently, wide range of disorders is considered within SADS, but its primary strength is obtaining fine detail of different subtypes of affective disorders and schizophrenia. There are two versions of SADS, adult and the children version. For the adult version of SADS is administered in two different parts, focused on the client's current illness and past episodes. Summary rating scales of SADS are made on a 6-point Likert scale, including mood and ideation, endogenous features, depressive associated features, suicidal ideation and behavior, anxiety manic syndrome, delusion hallucinations, forward thoughts disorder. The administration time is about 1.5 to 2 hours, and the administration items is more than at least 200 items. SADS has been used to predict the clinical features cause and outcome of various disorders, including major depression, schizophrenia, and bipolar disorder. It is also used to detect family patterns of schizophrenia and OCD. The child version of SEX is a semi-structured interview for children aged between 6 to 18 years old. Although Care SADS is based on research with major depressive disorders of pre-pubertal children. It also covers a wide range of disorders such as phobias, conduct disorders, OCDs, and separation anxiety. The total administration time is about 1.5 hours, and it can be divided into 3 phases. The first phase is a 15 to 20 minutes unstructured interview in which rapport is developed as well as an overview of relevant aspects of history, including the frequency and duration of presenting symptoms, their onset, and whether the parents have sought previous treatment. The second phase is unstructured questions regarding the symptoms, which are rated on the Likert scale, with 1 representing not at all and 7 indicating that they are extreme. Finally, ratings are made regarding behavioral observations, appearance, attention, affect. Interviewers are also asked to rate the completeness and reliability of the interview and to make a global assessment of pathology, the degree of symptomatology, and the level of impairment. Diagnostic interview schedule is another type of the Diagnostic interview schedule is another type of highly structured interview designed for non-professionals interviewers. The results are comparable between professional clinicians and non-professional interviewers. Clinical judgment is reduced to a minimum by using verbatim wording, specific guidelines, a clear flow from one question to the next, and simple yes-no answers. Total administration time is 60 to 90 minutes. Computerized administration and scoring programs are available. Adult versions of diagnostic interview schedule can obtain information regarding the client's life, and information is also requested regarding more current symptoms based on the past 2 weeks, past month, past 6 months, and past year. Different versions for children of the diagnostic interview schedule are available. Child, parent, teacher, young adults diagnoses are generated based on the combined ratings for the child and parent interviews. Some of the more problematic diagnoses, such as the autism, are based on an interview with the parent only. After talking about the structured interview, I would like to show some less structured examples of screening questions that can be used during the clinical interview. This is the screening questions that can ask to screen for anxiety symptoms and specific anxiety disorders. SCOFF is used to screen for eating disorders. We can ask these questions. As you can see, S, do you make yourself sick because you feel uncomfortably full? C, do you worry you have lost control over how much you eat? Or have you recently lost more than 6.35 kg in a 3-month period? F, do you believe yourself to be fat when others say you are too thin? F, would you say food dominates your life? An answer of yes or two or more questions warrants further questioning and more comprehensive assessment. A further 2 questions have been shown to indicate a high sensitivity and specificity for bulimia nervosa. These questions indicate a need for further questioning and discussion. So we can ask, are you satisfied with your eating patterns? Do you ever eat in secret? Okay, let's take a break now. Welcome back, everyone. So we have covered the 3 major topics. Now I'm going to talk about the interviewing skills. For this topic, it will be quite long, so get ready yourself a cup of coffee or anything before we continue. So the 5 skills that I'm going to talk about today: the attending behavior, non-directive listening responses, directive listening responses, use of interview questions, and directive action responses. Attending behavior. During clinical interview, much of your client's first impression of interviewer is based on what he or she observes as he or she speaks. Attending behavior is the non-verbal skill that all interviewers should use during clinical interview. So what is attending behavior? It is a micro skill to encourage clients to talk and show that the counselor is interested in what is being said. Your attending ideally is interpreted as an invitation to speak openly and freely. Without using words, you are communicating that you are listening to the person. Positive attending behaviors open up communication and encourage free expression. In contrast, negative attending behaviors inhibit expression. However, it is important to bear in mind that cultural background and previous experiences affect whether clients view a particular attending behavior as positive or negative. There are several components of good attending behavior that have been studied to some extent cross-culturally. They include eye contact, body language, vocal qualities, and verbal tracking. Eye contact is important to look at the person in one way of showing genuine interest in what the client is saying. However, you can make a person feel uncomfortable if you are stare at them too intensely. The best way of showing that you are listening to someone is by looking at them naturally. Research studies have found that for white clients, interviewers should maintain eye contact most of the time. In contrast, for the Asian clients generally prefer less eye contact. However, for most clients, it is appropriate to maintain more constant eye contact as they speak and less constant eye contact when you speak. For the body language, positive body language includes leaning slightly toward the client, maintaining a relaxed but attentive posture, placing your feet and legs in an unobstructive position, keeping your hand gestures unobstructive and smooth, minimizing the number of other movements, making your facial expressions match your feelings or the client's feelings, seating yourself at approximately one arm's length from the client, arranging the furniture to draw you and the client together, not to build a barrier. Mirroring is an aspect of body language that involves synchrony or consistency between interviewer and client. The interviewer's physical movement and verbal activity is in sync with the client. Mirroring is a relatively advanced nonverbal technique that potentially enhances rapport and empathy, but when done poorly can be disastrous. If mirroring is overdone, clients may think that the therapist is mocking them. Hence, mirroring should be used in moderation. Vocal qualities or paralinguistic consist of voice loudness, pitch rate, and fluency. The vocal qualities might influence clients' emotions. It is often determined not so much by what you say, but by how you say it. Effective interviewers use vocal qualities to enhance rapport, communicate interest and empathy, and emphasize specific issues or conflicts. In general, interviewers' voices is softer, but without losing firmness, indicating both sensitivity and strength. It is often useful to follow the client's lead or passing the client, which means speaking in a volume and tone similar to the client. Voice tone and speech rate can lead clients toward particular content or feelings. For example, speaking in a soft, slow, and gentle tone encourages clients to explore their feelings more thoroughly, and speaking with increased rate and volume may help convince them of your credibility or expertise. Lastly, the verbal tracking. It is important for interviewer to accurately track the content of the client's speech by occasionally repeating key words and phrases. Verbal tracking involves only restating or summarizing what the client has already said, without including your personal or professional opinion. To verbally track a client effectively, your internal and external personal reactions must be minimized, and your focus must remain primarily on the client, not yourself. So we have already talked about the positive or good attending behaviors. On the other hand, what are the negative attending behavior? At the end of the video, you will be asked to list out some negative attending behaviors during the clinical interview. Non-directive listening responses. There are 4 types: silence, paraphrasing, clarification, and summarization. Silence is the most non-directive of all listening responses. It takes time for interviewers and clients to get comfortable with silence. Primary function of silence is to encourage client talk, allow clients to process and reflect on what they have just said, promote introspection, allow patients to re-assimilate emotions. Silence can be a technique as well as therapeutic intervention. However, it must be timed appropriately. Interviewers should also explain to the clients the purpose of silence to reduce the client's anxiety, as great pressure might be placed on the clients to speak when the silence occurs. Paraphrasing involves restating or rewording the client's verbal communication in an accurate and brief format. It lets the client know you have accurately heard the central meaning of their messages and allows the clients to hear how someone else perceives them, which can further facilitate expression. There are several types of paraphrasing: simple paraphrase, sensory-based, metaphorical, and intentionally directive paraphrase. The simple paraphrase does not add meaning or direction. It rephrases the client's core messages. For example, the client said, "Thoughts are racing in my mind. I just can't concentrate. I'm confused." So interviewer can paraphrase it like in this way: "These strange things in your mind are disturbing to you." According to the past studies, clients have for the sensory-based paraphrase, the past studies show that clients have personal representational systems for them to use to experience the world. The most common representational sensory systems are visual, auditory, or kinesthetic. If you listen closely to your clients' words, you will notice that some clients rely primarily on visually oriented words. For example, they will say, "I see," or "it looks like." Others on auditory words, "I hear," "it sounded like." And others on kinesthetic words, for example, "I feel," or "it moved me." When interviewers speak through the client's representational system, empathy, trust, and desire to see the interviewer again are all increased. Let's look at the example here. So the client say, "I can almost hear what people in the office are saying behind my back about my hoarse voice now. And subtle messages I get from my boss sound to me like if I can't have a normal voice with customers, he's going to put me in the back office." So interviewer can paraphrase in this way: "It sounds like there is a lot of pressure on your job to get your voice better pretty fast, even though people are not saying this to you directly." So I have italicized the words that shows the auditory sensory system that the clients use. Another type of paraphrasing method is the metaphorical paraphrase. Interviewers can use metaphor or analogy to capture their client's central message. Many clients respond well to them, perhaps because so much of an experience is captured in so few words. For example, the client may say, "I'm prepared for some breakdowns along the way." Interviewer can say, "You don't expect it will be a smooth sailing." So there is the use of metaphor. Intentionally directed paraphrase. Solution-focused and constructive therapies intentionally use paraphrasing in a highly selective manner. This technique is used as a means of showing empathy and compassion, while at the same time helping the clients move beyond their negative or traumatic feelings from the past. The client may say, "I'm a bad person because I was sexually abused." The interviewer can say in this way, "So you have really gotten the idea that you are bad because you were sexually abused." So in this example, the therapist shifts the client's words from factual to perceptual. Clarification is used to make clear for yourself and the client the precise nature of what has been said. My mother is out most of the night, leaving me alone. She comes home at all hours. Sometimes she doesn't come home at all. So the interviewer can ask, what is your mother doing when she's out like this, to clarify what does the client mean. Summarization demonstrates accurate listening, enhances the client and interviewer recall of major themes, helps the clients focus on important issues and extracts or refines the meaning behind the client's messages. There are three different ways of summarizing: informal, interactive, and supportive summaries. Now we look at the informal first. Informal summary. Instead of saying, here's my summary of what you have said, we can say something like, let's make sure I'm keeping up with the main things you've talked about. For the interactive summary, interviewer pause while summarizing so your client can agree, disagree, or elaborate. At the end of the summary, ask if what you have said seems accurate. So the interviewer can say, you have mentioned about blah blah blah, am I right? So we can allow the clients to elaborate. For the supportive summary, openly acknowledge that your client has disclosed a large amount of information and then reassure them with supportive statements that help the clients feel good about what they have said. The way you ask a client for a summary should be supportive. Specifically, something like, I'm interested in what you feel has been most important of all you have covered today. Okay, let's take another break for now. Now let's continue with directive listening responses. Directive listening responses operates on the assumption that clients need guidance or direction from their therapist. Directive listening places interviewers in the position of director or expert. The effective use of directives requires interpersonal and clinical sensitivity. It also requires basic knowledge of psychopathology and diagnostic skills. There are different types of directive listening responses: feeling validation, interpretive reflection of feeling, interpretation, and confrontation. Feeling validation occurs when an interviewer acknowledges and approves of a client's stated feelings. The purpose of it is to help clients accept their feelings as a natural and normal part of being human. It contains approval and reassurance. Some potential effects of feeling validation include enhanced rapport, increase or reduce client exploration, reduction in client anxiety, enhanced client self-esteem or feelings of normality, increased likelihood of client-interviewer dependency, decreased client exploration of important issues. Here, I provide an example here. The client may say, I was so angry, I just wanted to follow the guy out and beat him up. The interviewer may say something like, I can understand being angry enough to want to strike back. Interpretive reflection of feeling are feeling-based techniques made by interviewers that go beyond the client's obvious emotional expressions. The goal of interpretive feeling and reflection is to uncover emotions that clients are only partially aware of and also in pursuit of deeper feelings that the clients do not articulate. For example, the client said, that teacher pissed me off big time. When she accused me of stealing her watch, I wanted to punch her leg out. Interviewer may use non-directive feeling reflection, so you were pretty pissed off. Damn right, the interviewer may continue by saying, you know, I also sense you have some other feelings about what your teacher did. Maybe you were hurt because she didn't trust you. So interpretive feeling reflection reflects the feeling of the clients. Interpretation, the purpose of it is to produce client insights or a more accurate perception of reality. When an interviewer provides an interpretation, the interviewer is in essence saying to the client, this is how I see you and your situation. There are two types of interpretation, the psychoanalytic or classical interpretation and also the reframing. Psychoanalytic interpretation is an interpretation based on the theoretical assumption that Unconscious processes influence behavior. By pointing out unconscious conflicts and patterns, interviewers help clients move toward greater self-awareness and higher levels of functioning. Let's look at the example. That teacher pissed me off big time when she accused me of stealing her watch. I wanted to punch her. And then the interviewer answered, so you were pretty pissed off. And then the client said, that's right. And then followed by the interpretive feeling reflection. When the interviewer do the interpretive feeling reflection, the clients have high probability to pause for a while and say, yeah, well, that's a dumb idea. It doesn't hurt anymore. After a while, when no one trusts you, it aren't no big surprise to get accused again of something I didn't do. The interviewer can interpret in the way. So when you respond to your teacher's distrust of you with anger, it's almost like you're reacting to those times when your parents haven't trusted you. Reframing is seen as an intervention that helps the clients to view their problems or complaints from another perspective. Reframing is used primarily when the interviewers believe their clients are viewing the world in a manner that is inaccurate or maladaptive. For example, this is an extract from a group therapy. So Peck may say, he's always bugging me, he insults me, and I think he's jerk. I want to make a deal to quit picking on each other, but he won't do it. Dan may answer, she's the problem, always thinks she's right, she's never willing to back down, no way, and I gonna make a big deal with her, she won't change. The counselor may reframe by saying, I notice you two are sitting next to each other again today, so I'd rather not be next to him. But the counselor can answer, I think you two like each other. You almost always sit next to each other. You're always sparring back and forth. You must really get off on being with each other. The rest in the group may say, wow, that's it. We always thought so. Confrontation is a statement that points out or identifies a client's incongruity or discrepancy. It ranges from very gentle to very harsh. It encourages clients to examine themselves and their patterns of thinking, feeling, and behaving, may result in personal change and development. For example, I originally met this girl in the chat room. My marriage has been dead for 10 years. So I need to do something for myself. She's only 20, but I'm set out to meet her next week in Dallas, and I'm like a nervous Nelly. I've got a friend who's telling me I'm nuts, but I just want some action in my life again. The interviewer may confront the client by saying, somehow you're thinking that having a rendezvous with this young woman rather than working on things with your wife might help you feel better. Now let's take another break. Now I'm going to talk about the use of interview questions, type of the interview questions and the guidelines. The use of during the interview process, we use different type of questions to gather information. The first type of interview question is general questions, which includes open-ended questions and closed-ended questions. These two we are very familiar with. For the open-ended questions, we can ask how are you feeling today? How are you feeling about being in the therapy? And closed-ended question, we can say, are you feeling okay about being in therapy? And for the indirect or implied questions are used when the interviewers are curious about what clients are thinking or feeling, but don't want to pressure the clients to respond. Usually begin with, I wonder. For example, I wonder what your plans are after divorce. Projective questions help the clients identify, articulate, explore, and clarify unconscious or unclear conflicts, values, thoughts, and feelings. It can be used to evaluate the client's values and judgment. For example, what if you could go back and change how you acted during that family gathering? What would you do differently? Another type of question is swing questions. Swing questions usually start with could, would, can, or will. They are designed to produce a more elaborate discussion of feelings, thoughts, or issues. For example, will you tell me what happened in the argument between you and your boyfriend yesterday? Another type of interview question is therapeutic questions. These type of questions guide the clients toward thinking, feeling, and acting in certain ways deemed by the therapist as healthy and therapeutic. Pre-treatment change question. There is some research suggesting that clients often begin improving between the time they call for an appointment when they meet with the interviewer during the first session. So before the psychotherapy begins, we can ask clients something like, what changes have you noticed that have happened or started to happen since you called to make the appointment for this session? Scaling questions help the clients envision their potential improvement more precisely. We can, on a scale of 1 to 10, with 1 being the very worst possible and 10 being the very best possible, how would you rate how well you have been handling your anger in the past week? We all very familiar with the scaling question. Percentage questions are quite similar to the scaling question. Essentially, they direct the clients to think about and define how an improvement would look, sound, and feel like. For example, I know you have been telling me about how depressed you have been feeling, and that sounds very hard. But I'm wondering how exactly would your life be different if you were 1% less depressed? Unique outcomes or redescription questions direct clients toward describing the unique ways in which they have accomplished some specific positive task. These type of questions are strength and success focused and encourage a deeper analysis of success by asking questions like, what were you thinking when you were able to stay calm and fight off your anxiety? Presuppositional questions are questions that presuppose a positive change has already occurred and ask for specific descriptions of those changes. These type of questions orient clients toward clear visions of success or goal attainment. So you can read the example in the slides. Formulator questions are the most famous among solution-focused therapy. These type of questions help the client to initiate and maintain a positive vision for the future and to analyze exactly what factors might contribute to that positive future. Externalizing question is designed to place the cause of psychiatric symptoms outside of the self. When working with depressed clients, externalizing question may be used to help the client begin to feel like fighting back against depression or depressive symptoms by asking them, how might you tell the depression thank you and goodbye? We put the question outside of the person. We put the the depression outside of the person. Exception questions provide clients with the opportunity to identify times when things have been different for them. For example, tell me about a time when that problem was not present in your life. Okay, so here are the guidelines in using questions that I have mentioned before. First, prepare your clients for questions. Always forewarn and prepare your clients for intensive questions. This can help the clients feel less defensive and more cooperative. Second, always use a combination of questioning and other listening responses such as non-directive listening responses. Do not use questions as your predominant listening or action response unless you are using a specific and accepted theoretical approach. Third, make your questions relevant to the client's concerns and goals. Fourth, use questions to elicit concrete behavioral examples and positive vision for the future. When clients mention about an issue, ask for clear and concrete examples and keep tracking verbal material as they tell their stories. Last, be careful when questioning clients about sensitive issues such as sexual issues, appearance, status, and etc. Always state your intention and asking permission from clients before asking sensitive issues. Like, for example, you can ask, I'm going to ask you some personal questions, but you don't have to answer if you don't feel comfortable to answer right now. Is it okay? Okay, now we'll talk about the last type of interviewing skills, directive action responses. Directive action responses are used to encourage clients to change the way they think, feel, or act. They are essentially persuasion techniques pushing the clients toward specific change. Interviewers evaluate what changes a client should make to improve his or her life. First, during interview process, we need to give explanation or psychoeducation to the client about the process of counseling. Also, psychoeducation is needed when clients are experiencing symptoms such as anxiety symptoms, but they don't know what that symptoms mean. Besides, interviewers should explain to the clients how to apply a particular therapy technique. For instance, interviewer explains to clients how to do a mood diary in the following 2 weeks. Second type of directive action responses is suggestion. It is an interviewer statement that directly or indirectly suggests or predicts a particular phenomenon will occur in the client's life. Suggestion is designed to move clients consciously or unconsciously toward engaging in a particular behavior, changing their thinking patterns, or experiencing a specific emotion. Agreement, disagreement. Agreement occurs when an interviewer makes a statement indicating harmony with a client's opinion. Agreement can enhance rapport, affirm the correctness of client's opinion, and reduce the client's exploration. Interviewers generally should not use personal disagreement as a basis for the therapeutic intervention. Disagreement may be subtle. Sometimes silence, lack of head nodding, or folding of one's arms, or therapist's neutrality is interpreted as disagreement. Two basic guidelines apply when you feel like disagreeing with clients. First, always remember it's not your job to change your client's opinion. It's your job to help him or her with maladaptive thoughts, feelings, and/or behaviors. Second, if in your professional judgment the client's belief or opinion is maladaptive, then you may choose to confront the client and provide him or her with factual information. The concept of approval-disapproval is similar to agreement-disagreement. Approval may enhance rapport and increase client self-esteem. It also fosters dependent relationships. When interviewer has the urge to disapprove with clients, remember that disapproval is ineffective in changing some behavior such as abusive, deviant behavior. It is because people engage in this behavior has been disapproved by the society. Second, your disapproval only alienates you from someone who needs your help to change. Also, by maintaining objectivity and neutrality, you can use explanation and confrontation to show your clients that you believe change is needed. If you cannot listen to your client's descriptions of his or her behavior without disapproval, refer the client to another qualified professionals. Disapproval is associated with reduced rapport, feelings of rejection, and early termination of counseling. Many clients will try to get quick advice from interviewers. What should we do then when clients seek advice from us? It's important not to give advice early, yet advise about how to obtain the resources or information the client needs to make a decision. For example, a client seeks advice from you because she just found out she is pregnant. So we can answer the clients in this way. Before we talk about what you should do, let's talk about what you have been thinking and feeling about your situation. Then we can talk together about the options. But first, tell me what you have thought about and felt since discovering you are pregnant. Self-disclosure here means interviewer self-disclose to the clients. The interviewer is self-disclosure here means interviewer self-disclose to the clients. So for example, the interviewer may say something like, yes, I do that too. I notice that I have a tendency to regress to being dependent unless I'm careful. I wonder if that's true for you. Self-disclosure implies commonality. However, using this technique with culturally diverse clients are risky and can damage the therapeutic relationship. It should be used in moderation. Urging is not common during clinical interviews. It involves pressuring clients to take a specific action, but there are situations when urging is more appropriate. These situations involve primarily crises, such as urge a child abuser to report himself to the local agency responsible for protecting children. Urging may be used in non-crisis situations such as therapists urge a client with anxiety disorder to face his or her fear. Before we have another break, I'm going to, this is another video about the somatization clinical interview. Pay attention to the part where clinician and clients have different treatment goals and the clinician tries to discuss with the clients about the treatment options until they can reach the mutual agreement. Please follow the link provided and watch the third video. We have a break now. Hello everyone, this is the final part of my presentation. So I found one article that talk about tips for successful clinical interview with older adults, and I found it interesting and it is suitable for this subject, for the adult psychology subject. So I include it in my presentation today. From past research, it is shown that the initial interview can be a very stressful experience for older adults. Same as interviewing clients of any other age groups, building rapport is the first step. Interviewers should follow the basic guidelines such as maintaining eye contact, demonstrating interest in and empathy toward the client, and etc. for building rapport with older adults. In addition, there are two simple strategies that seem to work particularly well for establishing rapport with older adults. First, offering the client an opportunity to ask questions as soon as possible upon arrival at the clinic or the interview room before the interview begins. This puts clients, particularly older adults, more at ease. Second, it is often worthwhile for the interviewer, who is likely to be younger, to identify a point of commonality with the client and to articulate these at an appropriate point during the interview. For example, if the older adult's interviewee is an opera fan, and the interviewer can say, "I'm an opera fan too." This technique is likely to reduce the client's feeling of dissimilarity, novelty, and formality, which are known to contribute to apprehension in the interview settings. Another aspect that should be taken into consideration is interviewer language. Interviewers should avoid patronizing speech. For example, speak in a way that shows you think you are more intelligent or important than someone, and be careful of the speech and volume of speech. For example, excessively slow or loud speech, as this can communicate a lack of respect. Also, interviewers should avoid the use of psychological terms and technical jargon whenever possible. Besides, paraphrasing and re-administering items can also ease discussion of sensitive topics. For instance, interviewers and clients may at times feel uncomfortable discussing certain topics such as sexual functioning or substance abuse. Interviewer can make normalizing statements when appropriate. For example, many people at times struggle with issues pertaining to substance abuse. Interviewer can also reword the items when necessary to probe for important information. Studies found that older adults denied having ever used street drugs, but admit having used recreational drugs. So you can see that this just depends on how we reword the drugs. They deny for using street drugs, but they admit for using the recreational drugs. Rewording is necessary sometimes. Interviewer duration is another factor that should be taken into consideration. Lengthy clinical interview can lead to fatigue, loss of motivation, and attention of older adult clients. However, it is challenging to balance the interview time constraints with demands of collecting accurate and comprehensive information. Older clients are very likely to be a good storyteller. They may share about their life experiences and not answering your questions. Although it is important to manage time in an interview, even the most experienced interviewers are at times uncomfortable with focusing on interrupting older clients for fear of offending them. So what can we do to gain relevant and adequate information within certain time frame, yet at the same time not offending our older clients? First, interviewers should proactively discuss time constraints at the beginning of session. Also, interviewer can devise refocusing statements for use if responses are tangential. It is also important to keep tightly focused on interview questions while still adequately sampling effective responses. So there's an example of the sample effective responses that the interviewer can use. Numerical ratings are, in terms of the interview response format, numerical ratings are difficult to older adults, possibly because of deficits in assigning numbers to specific contexts, such as moods. However, dimensional ratings can yield benefits with an older population. It is recommended that interviewer gives clients visual display of all dimensional rating scales. Also, interviewers should be vigilant for misuse of scales, especially when clients have very short response latencies and when the clients rate two or more consecutive pairs of items identically. Besides, older adults tend to have trouble comprehending the difference between maximum and average, as well as severity versus frequency. So it is important that interviewer provides illustrative example to ensure that older clients understand and use the rating scale appropriately. During clinical interview, we often need to gather clients' past history. When older adults are asked to recall life course information about mental health and specific symptoms, older adults sometimes cannot respond or become frustrated in posing a response. Sometimes older adults have difficulty accessing information about remote personal events, and those events that are remembered often lack sufficient detail. The use of additional prompts or cues to facilitate elaboration is worthwhile. To assist older adults to retrieve autobiographical information, general retrieval cues tend to be most effective. For example, the cue "click back to elementary school" is likely to be a more effective cue than the more specific, such as "think back to the time you attended your friend's 7th birthday party." Okay, so that is the end of my presentation. So here is the question and answer part. You need to answer and upload to the iFolio to Dr. Ponu. First question, list out at least 3 negative attending behaviors during a clinical interview session. So I have already mentioned about the positive attending behaviors. I would like you to think about 3 negative attending behaviors that the interviewer should avoid. Second question, how to conduct clinical interview with older adults in a professional way. So I have just mentioned about it just now. And the third question is your own opinion. What are your personal strengths and weakness in conducting clinical interview? And for the weakness, what can you do to improve the weakness? Here are the references for my presentation. And these are the list of videos with the link provided that you need to follow the link and watch the video accordingly. And here are the additional readings that I found quite useful and interesting for all of you, so you can read at your free time. So for the first reading is the diagnostic interview reading. I've already downloaded the file, and I will email to Dr. Ponu and he will upload to iFolio for all of you to download. And the second, third, and fourth readings, you can just follow the link, and you will be directed to the page for you to download and read. And that's all for my presentation. Thank you for listening.